Data-driven safety in neuromuscular monitoring. Residual neuromuscular blockade remains a leading yet preventable cause of postoperative respiratory complications. Traditional qualitative train of 4 testing relies on visual or tactile evaluation, which becomes unreliable once partial paralysis develops. This typically occurs when the train of 4 ratio exceeds approximately zero point 0.4 to zero point 0.6. At this stage, muscle twitches may appear normal even though the patient could still have significant weakness. Quantitative methods overcome this limitation by providing an objective measurement of neuromuscular blockade recovery. Integration with electronic record promotes data-driven automated safety process. There are many quantitative neuromuscular blockade monitoring techniques. Among the 4 types listed, electromyography or EMG stands out for its accuracy and compatibility with digital integration. It also avoids the limitation of motion-based sensors. This is why it is now the preferred method of quantitative neuromuscular blockade monitoring by anesthesia. Integration with AIMS enables the automatic logging of train of 4 ratios, providing accurate timestamp records of the train of 4 ratios and reversal data. This creates audit-ready documentation that supports interoperability and continuous quality improvement. It also supports decision making and ensures consistent care across providers and facilities, which enhances patient safety. The ASA sets practice guidelines and it establishes quantitative neuromuscular monitoring as a standard of care, requiring verification of a train of 4 ratio greater than zero point 0.9 or equal to zero point 0.9 before extubation to prevent residual paralysis. The FDA's 2025 cybersecurity guidance further mandates encryption, a security product development framework, and a software bill of materials for connected medical devices, ensuring that EMG systems transmitting patient data remain secure and compliant. Together, these standards align clinical accuracy, digital integrity, and patient safety. The shift towards quantitative monitoring isn't limited to the United States. Global health entities such as the European Society of Anesthesiology and Intensive Care are aligned, highlighting that a shared push for traceable, verifiable, and auditable anesthesia data. Ethically, CRNAs are held to the AANA Code of Ethics standards, which guide us to use technology that minimize preventable harm and uphold professional accountability. Legally, EMG based monitoring provides objective timestamp documentation that verifies adherence to ASA standards of care and demonstrate due diligence in evidence-based practice. These quantitative neuromuscular monitoring devices also convert subjective assessment into data-driven safety metrics, enabling anesthesia providers to verify their performance against measurable standards of care. This transparency promotes ethical equity and patient rights, ensuring that every patient receives consistent, evidence-based care regardless of the provider's experience or setting. Informatics brings together ethics, clinical practice, and legal protection as EMG data objectively validates clinical decisions and creates auditable records that demonstrate professional diligence and compliance with established standards. Quantitative monitoring directly improves patient outcomes. It reduces the incidence of residual paralysis to under 10%, lowers pulmonary complications by roughly 40%, and decreases oxygen desaturation and ICU readmissions. EMG-based system eliminates observer bias and enhances accuracy, making recovery assessments both reliable and reproducible. Talking about security and privacy, when EMG data is transmitted to AIMS, it becomes part of the patient's electronic health record and is therefore classified as protected health information under HIPAA. This requires maintaining confidentiality, integrity, and accessibility of the data. The FDA's 2025 cybersecurity guidance further recognizes the anesthesia monitors as connected medical devices that must use encryption, user authentication, and audit trails to prevent unauthorized access. These safeguards are an ethical extension of patient safety, protecting digital data ensures that quantitative readings remain accurate and reliable for post operative review, preserving both patient confidentiality and clinical accountability. The workflow: manual train of 4 testing is time consuming, prone to human error. EMG based quantitative neuromuscular monitoring automates the process, displaying real time train of 4 ratios and recording them directly into AIMS and electronic records. This reduces cognitive load and streamlines documentation for the provider. And when paired with electronic alerts, it helps improve compliance rate of documentation by 40%. In the post-operative setting, AIMS linked quantitative data enables PACU staff to view real-time train of 4 values and reversal timing, allowing for focused respiratory assessments and early detection of weakness. Aggregate analytics from these systems help identify performance trends, track adherence to extubation standards, and guide ongoing education initiatives. To bring it all together, quantitative neuromuscular monitoring has evolved from an optional technology into a professional and ethical standard in anesthesia care. EMG based system integrates objective physiological data directly into the patient's electronic record, creating a measurable improvement in safety, accountability, and workflow efficiency. This integration supports evidence based, legally defensible practice while aligning with regulatory frameworks from the ASA, FDA, and HIPAA. By merging clinical precision with digital integrity, quantitative neuromuscular monitoring exemplifies how informatics can close the loop between monitoring, decision making, and patient outcomes. And these are my references.